Hi, everyone. Welcome to our pilot virtual shadowing session. Today we have Natasha, who's giving a interesting case on an interesting neurology pediatric case. But just to intro, my name is Jed Obra, pronouns he, him, his, and I am this year's FAC president.
Hi everyone, my name is Shannon Rasho. I'm this year's external vice president and my pronouns are she, her, hers.
Hi everyone, I'm Raphael, pronouns he, him, his, and I am this year's FAC representative.
All right, and so we'll just be keeping track of time and asking presentation related questions as well as any Gen member community questions for you, Natasha. So yeah, with that, yeah, and with that, we'll segue to your presentation.
Okay, so the dates are going to be off on this because I originally gave this at the beginning of October for student rounds at Stanford. So at Stanford Med, we have student rounds that happen once every week, and it's just for like med students to present sort of cool cases or interesting learning cases that they've seen to other students, and sort of like first and second year students who aren't in clerkships yet or aren't in the hospital, they get to learn how we think about these cases. So this student rounds, the big title or the introduction was there's an 8-year-old previously healthy female with recurrent blurry vision and new leg weakness. So short introduction about me. My name's Natasha. I am a 5th year out of 5 years. At Stanford, there's lots of research opportunities and funding. So I took a research year in between my 2nd and 3rd years and did health disparities in pediatric surgery research. I'm applying in child neurology this cycle. I thought I was applying in a general surgery and then general pediatrics. So if anybody has any questions about any of those 3 things, feel free to email me here below. And then I just put in some fun hobbies here too. Okay, so here is the presentation. So I got this, this is Lucille Packard Children's Hospital, by the way, the Stanford Children's Hospital. So I met this patient, we're gonna call her Penelope, when I was inpatient on one of the child neurology inpatient units. So she came with her mom, and they had just got done with a road trip going from the East Coast to San Francisco to visit her grandmother whose cancer symptoms had gotten worse. And her mom said at one of the hotels they stopped at, Penny felt leg weakness while swimming, and when she got out of the pool, she fell on the pool deck. Her vision is also blurry again. So what would be some of the questions that you ask when you just, maybe we can come up with like 3 questions that we would be curious about when we hear this from a parent.
Did she hit her head?
That's a really good question because we want to make sure that she did not hit her head, or if she did hit her head, we want to get more imaging just in case there was trauma. She did not hit her head, luckily. She was able to catch herself. Maybe 1 or 2 more questions.
I'd ask if she was eating enough or was hydrated enough.
Yeah, that is a super good question, because even though this is a child neurology inpatient service, you never want to rule out one of the more benign or not as worrisome causes. So maybe she had just low blood sugar. Maybe she was hungry. Mom said no, her appetite was the same. We had just eaten lunch, regular time shortly before that. Another question that we would want to ask, or we made sure to ask, her mom said her vision is blurry again. And that kind of set off sort of alarm bells in our head. Like, what do you mean her vision is blurry again? Did she have past vision blurriness? You would also want to ask questions about what kind of leg weakness. When people say weakness and patients present that to you in clinic or at the hospital, you really want to ask details. Some people say leg weakness and they mean leg pain. Some people say leg weakness and they mean leg numbness or tingling, like when you sit on your foot for too long and then you feel that numb feeling. So weakness can mean a lot of different things. So you want to ask your patient to sort of like characterize the weakness. Okay, so we ask more questions. Oops, sorry, forgot about that. So we asked more questions, and Penny's mom actually said that all of these symptoms began in March. So I saw this patient around August. So she said that in March, she had a 1 week history of, and in this presentation, because it was meant for med students, you're going to see lots of acronyms and things like that, and I will try to clarify as much as possible. So she had a 1 week history of fevers and cough and fatigue. She had elevated CPK levels, which means elevated this is creatinine phosphokinase levels, I believe is what it stands for. It's a muscle marker. And then intravenous fluids was how they sort of treated it, and they thought it was some kind of infection. So this is when she got sick. She was previously healthy before this. And then in May, she had 4-day history of right eye pain, and then she had gradual to complete right eye vision loss, and they diagnosed her with optic neuritis, which is one of these things where you image the brain and you see that the optic nerve is sort of there's a problem with the optic nerve. There's demyelination in the optic nerve. So this is optic neuritis. They diagnosed her with this, and then they took all of these labs and imaging. Mycoplasma, they said that this was sort of the virus that she had earlier in when she presented in March, but then she had a lumbar puncture, which is what LP stands for. And they took all of these sort of markers. So oligoclonal bands, people test for those if they're thinking multiple sclerosis, MS. MOG antibodies are another sort of subtype of MS. It's a demyelinating disease. And aquaporin 4 antibodies is another test for something called neuromyelitis optica, which is sort of going with the optic neuritis thing. So they did all this testing, and then they gave her IV steroids and IV immunoglobulin with a steroid taper, as well as azithromycin for her infection. So this is sort of the treatment for optic neuritis. You give high dose IV steroids and you hope that they improve. And she did improve. Her right eye acuity improved. However, she then in June, she got more eye problems. So they did labs again, and they were negative for all of these things again. And then they gave her steroids again, but with a longer taper. So here was 5 days, here was 8 weeks. And then she then improved her visual acuity, but it was worse than before. And there were new concerns for a persistent blind spot that wasn't there before. And then here was when we met her. So she had the painless blurry vision, so painless this time. It was painful here. And then she had leg weakness, which was new. And she also had some new headaches. So this was when she was admitted to Lucille Packard. So just kind of looking over this, you think, you know that she had the diagnosis of optic neuritis, and she was only given a very short steroid taper this time. So you think like maybe the steroid taper was too short and the optic neuritis sort of recurred here, which is why they did the longer steroid taper. And then you wonder, why is she getting it again later on, especially with the new leg weakness, you're really concerned. So you want to do a physical exam. You want to listen to sort of the lungs, the chest, the heart. You want to look inside her eyes for sure. But we're going to talk a little bit about the neurological exam, which is separate than the physical exam. So there are 7 parts of the neurological exam. Mental status, which is sort of asking questions, seeing if they're alert and oriented, seeing if they have good fluency in their speech, if they sort of know what's going on. Cranial nerves, and do you guys know how many cranial nerves there are? Anybody?
12.
12. There are 12 cranial nerves. So you basically could test all of them if you wanted to. And you basically go through a cranial nerve exam to make sure that you test all of these. And then there's a motor where you kind of see how they can move and see what their sort of muscle strength and tone is. Then there's sensory, where you see if they can feel you touching, and there are different kinds of sensations. So they're like, you can do light touch, which is just sort of gently brushing them, or pinprick. And there are special tools to do pinprick because there are different tracts in the spinal column that control different kinds of sensations. So you can kind of see where things are, where injuries are, if like they can feel pinprick, but they cannot feel light touch. Then the reflexes, everybody knows about reflexes with the little reflex hammer. There are many reflexes you can test. Coordination, so you want to see if they can do things like rapid alternating movements. You can see if they can do like finger taps. Sometimes if people have cerebellar issues, which is like the small brain in the back part of your head, if they have cerebellar issues, they might not be as coordinated. And then you check their gait, you see if they can walk normally. So 5 of these, for anybody who's aspiring to be a neurologist or really wants to get a really good neuro exam, 5 of these can be done on any patient, no matter how old, how young, like if they're awake or if they're asleep, you can test 5 of these. Especially in the advent of telemedicine, it's really important to know that you can still test 5 of these. It's coordination and gait. I mean, if they're sort of unconscious, you can't test coordination. If they cannot walk, you can't test gait. But always remember, especially just by looking at a patient and observing them, you can test 5 of these, the ones in yellow. And it's important in child neurology to know that your examination starts once you say hi to the patient, once you walk in the room, because you'll be seeing them walking all over the place, playing with their parent, interacting. And that tells you stuff about their mental status, that tells you stuff about their motor skills. So make sure you always keep a good eye on your patients. Okay, so here, I'm just gonna like list, here. I'm gonna list what happened. So mental status was great. She was awake, alert, and interactive. She was totally fine, appropriate for her age, which was 8 years old. And cranial nerves. So pearl means pupils are equal, round, and reactive to light, which is normal. EOMI means extraocular movements were intact, which means when you made her look left and right and up and down, there was nothing abnormal to that. What we did see, which was abnormal, was the things that are bold here. So we found that her right optic disc, when we looked in with that fundoscope, the eye examiner, that it was a little bit not as vibrant. There was pallor there. She had a right afferent pupillary defect, which I'll explain on the next slide. She had right eye red desaturation, which means when she closed her left eye, things that were vibrant red did not look as red as they should have been if her left eye was open. And then she had right superior quadrantenopia, which means she had a blind spot in the right upper quadrant of both eyes. Everything else was fine. So here is what the pupillary defect looks like. So when you shine a light in one eye pupil, what do you expect?
It gets smaller.
It gets smaller, right? Your eyes sort of acclimate to the light and it gets smaller. Lets less light in. So here's the normal response to light. However, if you have an afferent pupillary defect, you shine the light in and the eyes might constrict, but it's not going to constrict as much as it did if you shine the light into the other eye. So this signals that there's something wrong with the brain here. Okay, motor was fine. She had maybe less interosseous, so in her fingers, a little bit of less strength in her fingers compared to the left side, but otherwise fine. And sensory was fine. Her reflexes were also fine. And coordination was perfect. We actually observed her. This is like where observation comes into play. When we met her, she was doing origami. So her coordination, as we saw by observation, was already really good, but she was fine as well with the tests. Her gait was difficult. So tandem walk is like the sobriety test, or like pretending you're on a tightrope, putting one leg in front of the other like this. So she had difficulty with that. And then she had unsteadiness when moving from lying to sitting in bed. So I just highlighted all of the abnormal things here. And then we did some brain and spine imaging, because when you see all of these things and you think about eye problems and then you think about motor problems as well, you want to find, even though there might be multiple diagnoses, you want to find sort of the unifying diagnosis that would make all of these things sort of make sense. So we did some brain and spine imaging, because if you think about, you have multiple defects, motor and eye, this might be a problem in the brain. It might start where everything starts, which is in the brain. So we did defects, and I'm sorry that I didn't put a normal brain imaging here, but hopefully we can spot some defects here. So I want to teach you guys a little bit about brain imaging. So we have T1 and T2. Does anybody know about MRIs at all? Or like, yeah. So what is the difference between T1 and T2? Okay, so totally fine. So MRIs of the brain, so magnetic resonance imaging. You guys might have learned about this in pre-med, some pre-med classes, or about physics, because it takes a lot of like physics and magnets and stuff that I can't explain to work out MRIs. But there are two different kinds of sequences called T1 and T2. There are many different kinds of sequences, but the main ones are T1 and T2. Basically, T1 shows your so it's sort of highlighting what is bright and what is not. So for one of these, white matter is bright and gray matter is dark. And then for the other one, it's just like the inverse of color. So if you see here, for the T1, you see that the brain is like this, and you expect the brain to be like this, but you see that the white matter is dark and the gray matter on the inside is, vice versa. The one of the white matter versus gray matter is dark versus light. So we'll just go through her her scans here, and you see all of these white patchy parts. They're not supposed to be there. So I hope you can see this moving. All these white patchy parts here, those show sort of patchy, ill-defined enhancements. And contrast, when you give contrast to someone who's getting an MRI, it signals at new lesions, because contrast can cross the blood-brain barrier. So it signals at new lesions that were not there before. And here you see the same thing. So you see that all of these white parts, those are not supposed to be there in a healthy brain. So unfortunately, she had lots and lots of lesions in her brain, and I sort of blew them up here. So she had some hyperintensity in her dorsal medulla, which is really close to the bottom part of your brain, close to the cerebellum. And she had some right optic nerve enhancement increase from prior scans, which makes sense with all of her right eye problems. And the dorsal medulla is one of those parts that control sort of coordination and gait and balance. So this also makes sense. And this is one of the reasons why I really love child neuro or neurology, is because all of her deficits in her neuro exam, you could sort of localize and explain by looking at her brain imaging, which was really cool. Okay, so now we want to think about what might be going on. So we see that in these images, there is a demyelination, and I'm sure you've all learned about myelin. Can someone tell me, like, very briefly, what does myelin do?
It increases the speed of a neural response, or like just neural signals.
Yeah, it encases all of these nerves and neurons, and it increases the speed. So it, like, I mean, there are those pictures where you see like the sort of potentials jump because of the myelin. So we see here that things have become demyelinated. All of these lesions are demyelinated, which means that those signals don't jump as fast, which is why her vision started being not as responsive as it normally is in a healthy person, and why her weakness happened. So we think about demyelinating diseases in child neurology, and there are so many, and we use like acronyms for everything, but here I sort of laid them out. And here I tell you about all these different kinds of demyelinating diseases. So I want to draw your attention to optic neuritis, because that is what she was diagnosed with at first. So severe eye pain and vision loss, which she had when she first presented and they diagnosed her, typically monocular, so one eye, but can also be both eyes, and it's a clinically isolated syndrome. So this would have been best case for her. Optic neuritis, clinically isolated, nothing else is wrong with the brain. She just has some demyelination in one of her optic nerves, but you give her steroids, she kind of bounces back from this, and it's totally fine. However, there are other demyelinating diseases that are not as benign. So everyone knows about multiple sclerosis. It's clinical lesion, signs or lesions separated by time and space. And you're gonna hear this a lot when you hear about multiple sclerosis, when you learn about it in med school or wherever you go in the future in your future healthcare careers, because time and space are an important distinguishing factor of multiple sclerosis. So you need lesions or clinical signs separated in time. So it can't be all at once. It's going to be like she has eye pain here and then she gets weakness 5 days later or 5 weeks later. It's like separated in time. Separated in space means that the lesions are in different parts of her brain, or the lesions are in different sort of muscle systems or organs in her body, like the vision and the muscle weakness. So separated in time and space. Lesions are definitely more well-defined in multiple sclerosis. And this is probably more than you need to learn right now, but if anybody is interested in neurology, please reach out to me, because these are different kinds of demyelinating diseases. And you sort of ask different questions and it comes up with different symptoms if you have these. So she never had encephalopathy, which is like confusion, and it signals at sort of inflammation all over the brain. She never had this. So we kind of took this off of the differential diagnosis. She never had a spinal cord lesion correlated with a sensory level, which means like everything under this sensory level, she doesn't have sensation or things like that, and everything above, she's fine. She didn't have that. So we took this out of our differential. So sort of like you just keep asking questions and keep running tests, and you're able to come up with one diagnosis. So thinking about her, she had vision loss, or she had painful vision loss back in sort of July or whenever she started having it. And now she's having muscle weakness. And then we had past imaging, and right now it's increased. All of these deficits are increased from prior imaging. So she does fulfill the criteria for multiple sclerosis. So we were kind of going down that train of thinking. And after looking at some of our lab tests and thinking about the sort of the criteria of lesions or clinical signs separated by time and space, one of our neuroimmunologists who specializes in demyelinating diseases diagnosed her with multiple sclerosis. So one of the really important things in any healthcare profession and in any sort of specialty is making sure you educate parents and patients really, really well. So this comes from like one of the Pediatric Multiple Sclerosis Foundation websites. And it's what we talked about with her mom first and foremost, because multiple sclerosis sounds like a really, really scary disease. You think about like older women who like slowly can't walk and things like that. So we really want to educate parents, and it pays off so much to sort of create that bond with your patients and their families at the very beginning of any diagnosis, to make sure that they trust you and that they know that you're giving them all the information that they want to hear. So here I'm just going to go over sort of the epidemiology of pediatric multiple sclerosis, because it's different than adult multiple sclerosis. So onset prior to the age of 18, which was her, the incidence is very low. So less than 1 to almost 3 out of every 100,000 patients. There's a female predominance. It's very rare to get it before 10 years old, but she did. It's usually, sort of in the early teenage years. And the relapsing remitting course happens in virtually all pediatric patients. So if you guys do a little bit more research, you'll see that in multiple sclerosis in adults, there are different kinds of patterns of disease. There can be relapsing and remitting, which means you get the symptoms and then they get better. And then you get the symptoms and then they get better. Or there can be other kinds of courses where like you get the symptoms and they sort of get better, and then you get worse symptoms and then they sort of get better, and it just gets worse and worse and worse. But relapsing remitting is what virtually all pediatric MS patients see. Here are the risk factors. So if there is some kind of injury to the central nervous system, you can have like a double hit theory. So genetic susceptibility plus an environmental trigger. So if you have multiple sclerosis in a first degree relative, you have a 5% lifetime risk, which is higher than the general population. There's one theory that low vitamin D results in immunoregulatory effects, which then puts you at risk for pediatric MS or MS in general. And then you can think about viral infections. Sometimes people say that if there is immunological vulnerability and the virus gets in there, there might be a stronger risk for pediatric MS. So it sort of has to be this perfect storm sort of environment for pediatric MS to happen. And here's sort of the presentation and the criteria. So you guys can read this through yourself, but basically it's what I was talking about, sort of separated in time and space, clinical signs or neuroimaging signs, or you have sort of like one episode associated with MRI findings consistent with the time and space criteria. Pediatric patients are more likely to present with isolated symptoms. For example, they have isolated optic neuritis or encephalopathy, which is like confusion alone, which is sort of what our patient Penelope presented with. She had isolated optic neuritis and then things just got worse and worse and compounded. And here are differences between pediatric MS and adult MS. So we have different time courses. For pediatric MS, it's just relapsing remitting. For adult MS, there could be different kinds of patterns of disease. You recover from your relapses in 4 weeks about with pediatric MS, and you see that that's faster than adult MS, so it's a little bit better there. You get more relapses, however, with pediatric than adult. And unfortunately, you see here that over half of children with pediatric MS demonstrate declines in cognitive tests in 5 years. So even though pediatric MS, there's like really, really good treatment for it and good treatment for the relapses, and you kind of keep all of the symptoms at bay, things get through. And about half of children, 50%, demonstrate declines in cognition because of all of these sort of symptoms. And it's also because as a child, you're still forming these synapse connections and having insults to your brain during this important time of growth really makes a big difference sort of forward in your life. Whereas with an adult, you've already formed all of these connections or most of them. So having hits to your brain and your CNS, your central nervous system, doesn't make that much of an effect. So as you can see here, pediatric MS sort of gives better symptoms and you recover quicker, but at the same time, because of the time that you're getting this disease, it really is devastating to your future. So back to our patient who was still really, really, really good at origami. Nothing was really bothering her except for this little bit of leg weakness and eye blurriness. How we treated her was steroids for 5 days while inpatient, and this was really high dose steroids. And then she was started on oral steroids, and the taper means she takes less and less every week. And then remember how I talked about vitamin D sort of like contributing to pediatric MS risk factors? We gave her vitamin D supplementation. We gave her some stomach protection while she was on the steroids because it can give you really bad stomach issues. And then she had a plan for outpatient rituximab infusions, which is a disease-modifying agent that goes after, I believe, CD20 on your cells. So we had her plan, and what was really important here was that her mom started crying when she saw the images because they were so devastating. You saw all the lesions, and when you think about your kid that has all these brain lesions, obviously you get really emotional. And when you think about sort of the prognosis for pediatric MS, you can get really emotional there as well. But what's really important to think about for your futures as healthcare providers is that you want to be able to educate parents and patients. You want to be able to give them a plan. And I put this here to remind myself that when she was sitting in bed, giving her mom all of this devastating news, she looked amazingly healthy and so well cared for. And what one of the physicians caring for her with me told mom was that we see all of this going on in her brain. We see all of these lab tests, but what we see in front of us is different. And we want to concentrate on what's in front of us, who's a really healthy appearing and really normally functioning and happy 8-year-old girl. And we as a medical team really want to help her continue to be like this. So just by saying that and just by putting things in context for a parent can go a very long way. So that's just one of the really big takeaways that I want you to take away from this talk. And that was it. That's the end of the presentation. This was given in October, so I just told everybody about all of these awareness months. And then on the day that it was given, it was like National Firefighter Dog Awareness Day. So I had that there too. But that was the presentation. Do you guys have any questions at all?
Yes, well, thank you so much, Natasha, for your time and being able to present for us. Yeah, so I guess we'll segue to some presentation focused questions.
Yeah.
For our first question, I just want to ask, are there any follow-up appointments with this patient, or what does the follow-up care look like after the patient's MS diagnosis?
Yeah, so her follow-up care was really unique because if you remember, she was just visiting from the East Coast because they were visiting her grandma. So she actually road tripped back after one of her rituximab infusions. We made sure that she wasn't allergic to the rituximab and that she was doing okay and not sort of decompensating, but she road tripped back to the East Coast. So she had to start following up with her neuroimmunologist there. So once she got there, she had an initial follow-up appointment. We communicated all these findings with those doctors on the East Coast. And she had an initial follow-up appointment just to like sort of, so they can check her out, so they can see her. And then follow-ups for pediatric MS, once the disease is under control, would be every 3 to 6 months. And you would get you would get re-imaging of the brain every 3 to 6 months, depending on what you see. And you want to see if there are new lesions, if you need to modify treatment. But you would get follow-ups and re-imaging every 3 to 6 months, and then you would get rituximab infusions depending on how the lesions look.
Thank you. I guess a follow-up, I just want to ask how, why, or how do steroid treatments help MS, or why do we use steroids to treat the disease?
Yeah, for sure. Does anyone know what the mechanism of steroids are? Like, what does steroids do? Very like generally, not, oh, it binds to this receptor or whatever.
I know it decreases inflammation and
yeah. So that was the answer. Super simple. Obviously, there are like more intricate and complex ways that steroids work, but it decreases inflammation. So while you're on steroids, you are immunocompromised, which is like really important during COVID-19 times, thinking about like immunocompromised patients getting COVID-19. But the decreasing of inflammation is really important because with these lesions and demyelination, that is inflammation happening. So you decrease this inflammation so that the lesions get smaller, so that there's not as much like angriness in the brain, and that's how her vision corrected, or how your motor or whatever is affecting you gets corrected.
Awesome, thank you.
Yeah. Any other questions?
I can go next. Okay, this might be a long one.
Yeah.
How do you treat patients and their families with compassion while simultaneously balancing empathy and kind of the touching side with the business talk, like the treatment plans and the symptoms, the risks, all the like the heavier stuff that you have to obviously present to them when you give them a relatively difficult or heavy diagnosis such as multiple sclerosis?
Yeah, so I kind of touched on this in my talk. You really want to meet the parent and the patient where they are. So when you give them a diagnosis, you want to judge, and this is like every healthcare provider's sort of responsibility, but also subjective opinion. You want to judge how they take in this diagnosis. Some families might have doctors in their family. They might know a lot about this diagnosis and the prognosis. So you're able to use a little bit more jargon if they understand that. Some families might not have the health literacy, or they might be afraid of this diagnosis. So you really need to meet them where they are there, and you need to start with the basics and explain in very layman's terms what's going on. Throughout your entire explanation of the diagnosis and prognosis, you want to check and use your own judgment to see how the patient and the family are taking this in. Sometimes it really is worth a lot to stop, let them be with each other, let them take a break and let it sink in, and then go back and teach some more. Dumping all of the information on them at once sometimes isn't the best at all, even though some patients may want it all, because you'll go back and you'll realize that they were so shocked when they got the diagnosis to begin with that all of this information just went way over their heads. So one, you want to be sure that you meet the patient where they are in terms of sort of health literacy, understanding what they want to know and what you think that they are capable of taking in at that time. Two, you want to be sure to really tailor your education to their level of health literacy. Three, you want to go and check in on them again afterwards, because after receiving like a really bad diagnosis or any bad news, some people might not let everything sink in or might not have heard everything you said. So you want to check back in check back in on them later. And then four, you always want to remind the patient that this is a team decision, that the healthcare team is there for them, and that through every single point of the patient's treatment and prognosis, that the patient and the family have a say in everything that's going to happen. So you want to make sure that you sort of appeal to them as a compassionate team player, and that you're on their side. You don't want to be talking down to them. You don't want them to be sitting down and you're standing up. Everything matters when you're having these conversations in terms of room dynamic and logistics. You want to be eye level with them. And you want to make sure that you're really judging their emotions and seeing how they're taking in this news. At the same time, you also want to be sure that with children especially, you want to not make things more scary than they need to be. So there are some really anxious kids who could really freak out, and you could do a real number on their mental well-being and mental health by giving them all this information. So some physicians like to talk to parents privately without the kids in the room first, and then have the parents decide how to tell the patient. Some physicians like to sort of give things out in layman's terms and then talk to the parents separately about prognosis and treatment so that the patient can be in there at the same time. It depends on the doctors or the nurses or whatever healthcare professional style of giving bad news, but it's really, really important that you remember, especially in pediatrics, that you can really affect a kid's mental health when you're giving bad news like this. And then I'm going to pull it up here. There is a sort of mnemonic that helps with giving bad news. So it's called the spikes model. Let me share my screen so we can see it all at the same time, and then the people at home can see it too. Let me find it in this slide. Okay, here we go. I'm going to share my screen really quick one more time. Okay, so it's the spike model. Can you guys see that? So spikes is an acronym. There are lots of acronyms in medicine you guys are going to find, or you guys have already realized. So it's 6 steps. So it's the setting. Like I said, you want to make sure that you're not standing up and they're sitting down, so it doesn't look like you're lording over them and like you are being like an authoritative figure. You guys both want to be sitting down, same eye level, and you want to make it sort of an intimate setting. You do not want it to be in a crowded waiting room. You don't want it to be in front of people who don't need to know this information, like random strangers, sort of like in the hallway. So make sure the setting is set up. You want to see what their perception of the diagnosis is. So you want to ask them, like, before you give any bad news, they might already have had research stuff. They might have already had someone else talk to them. So you always want to say, like, what do you understand about your daughter's prognosis? Or what do you understand about what's going on with your daughter? So judge their perception. Then you want to invite them to ask questions. You want to have them sort of be part of the discussion you want to share your own knowledge, and you want to invite them to share knowledge that they might have too, and sort of meet them where they are and address things, they might have heard sort of false knowledge about certain things. Like pediatric MS is not the same as adult MS. So they might have had a friend with adult MS and they might be especially scared. So you want to share knowledge and invite them to share their knowledge. You want to address emotions. So this is a really important one. People reacting to bad news might react in a whole myriad of ways. So some people might be super angry, some people might be super emotional. You really want to address these, and you want to say, like, I can sense that you are very angry. I can sense that you are very mistrusting, or I feel like you are very anxious. Like, what can I do to help you with this? What can I do to help alleviate some of your anxieties? So you want to definitely address emotions. And then at the end of every conversation, you want to summarize. You want to summarize everything you talked about, because you talked about a lot, and you want to develop a strategy or a plan for moving forward. And a really good way to talk about sort of judge what your patient or parent has understood about what you talk about would be the teach back procedure. So you can ask them, like, I've said a lot during this conversation. I know it's a lot to take in. Can you just sort of help me summarize what you understood or took away from this sort of conversation? So then you see what the big things they took away from the conversation were. And if they didn't get one of your big main ideas, you can reiterate it or re-emphasize it either then or during a future conversation. That was long. Sorry. I hope that was really helpful.
It was. Thank you.
Yeah.
I had a question specifically about MS. So you mentioned that no cure to MS yet. What scientific advances are being made, if you know about MS, and how close are we actually to curing it?
Yeah, so lots of scientific advances. There have been so many different drugs and disease modifying drugs that have been put or are right now in trials to help with MS. So there are lots of new things. There are over 20 something ways to treat adult MS. And it's a little bit harder with pediatric MS because getting these kids for trials is a little bit more nuanced and more complex. But there are tons of drugs and treatments out there that are being investigated right now, which is really exciting. So it's a really exciting time for neuroimmunology and demyelinating diseases. In terms of a cure, I really don't know if there is anything very plausible for a cure for MS right now. Right now, it's more of managing the symptoms as well as managing the relapses and making sure that things don't happen again with these disease modifying agents. It's really hard thinking about sort of, you give a drug and it's the cure for MS, especially in one of these diseases that are progressing and sort of you get worse and worse and worse. So, I hope that there is a cure. There are tons of foundations pouring money in and getting donations and raising awareness to finding the cure. So I'm sure that with time, there will be a really good advancement in the future.
Awesome. I just wanted to clarify, did you you worked with this patient and you made the presentation for it, right?
Yeah.
I just wanted to ask, when you first encountered this case, did you have your own differential before the MS was diagnosed that may have been different because you hadn't seen any tests yet?
Yeah, so everyone was actually thinking about sort of some of the demyelinating diseases. So one of my slides showed like all the different demyelinating diseases. And what was a little bit on everyone's mind, but everyone kind of wanted to wait for the tests because it is such a bad diagnosis, was pediatric MS, because she did have diagnosed optic neuritis already. And we know that pediatric MS presents with a one like sort of like just one sort of symptom. It doesn't present with multiple things. And then she started getting the weakness in her legs. So I was thinking pediatric MS. I was also trying to think of other things like, oh, maybe she didn't eat enough. Like maybe she has like some cornea problem in her eye, et cetera, et cetera. But as we continued asking questions, and especially during the neurological exam, things were really, really significant for pediatric MS, unfortunately.
Okay, thank you so much
Yeah,
for your answers. So we'll transition to questions that our Gen members have
for sure.
for you. For our first question, what's your advice for undergrads who are looking to get into research?
Yeah, to look for them getting into research specifically, I would, so you guys are all at UC Davis, right? Yeah. So I would there for every university, there is like a directory of faculty and staff. I'm guessing UC Davis is the same. And I'm sure you can search under faculty and staff and just like search different interests, or you can just like Google UC Davis pediatric MS research and see who is there and who is like the top researchers, some of the top researchers at UC Davis who are accessible to you. And then I would just reach out. It's really, really something to realize that you're an undergrad and people really want to share in research and share in people's interests. I would send an email, I would introduce yourself, make sure you give a little background about yourself, and then say, I am extremely interested in so and so. And do you recommend any ways that I can get involved in research? Do you have any undergrad appropriate research projects that I could help you undertake? And people will be more responsive than you think. I would start there. I would start very locally, and I would start at UC Davis because they already have a bias to you guys. Yeah, that would be my advice.
Yeah, I just want to add to that, like a lot of the clinical research opportunities are at the UCD Medical Center, the Mind Institute, the on-campus research opportunities, a lot of them will be like bench research, wet lab research, epidemiology research, survey, like psychology research as well. So definitely check out the directories.
Nice. And I would also ask older students who might have like the same interest to see if they may have encountered, people who are willing to give undergrads research projects. Especially because you guys have such a really strong system of Filipinx people associated in or interested in healthcare careers. You guys have so many people to ask. So that's also an option. Any other general questions?
Yes, sorry. I forgot. I had to unmute. What is the life of a medical student like?
Yeah, it's different for different medical schools, and it's different for different um, levels of where you are in medical school. So I will just give you sort of my take on the life of medical students. So at Stanford, everything is pass fail, and you are not ranked within your class. So there is no class rank, and they do this because they realize that tests and exams are not the only way to judge intelligence and what makes you a good doctor. And they know that their tests and exams are rigorous enough that, if you pass and if you get through Stanford Medicine, you're going to be a good doctor. So everything is pass fail and not ranked. So the first 2 years are pre-clerkship or pre-clinical years. So you're learning like in lectures, you're learning in didactics, you're learning in structured classes. So a lot of them, I didn't go to school during COVID-19. So a lot of them were like in-person lectures, but they were also recorded. So you didn't really need to go to class if you didn't want to at that time. You could just watch the recordings at like 1.5 or 2x speed later on, and you could sort of learn the same things, which was really nice. The first 2 years, because it's pass-fail, because everything is recorded, because there's so much support. There are some classes that cannot be recorded. So anatomy classes, and like when they actually teach you how to do the physical exam and stuff like that, you have to go. But other classes were recorded. And because there was so much freedom to learn whatever way that you best learned, the first and second years were great. I made lots of friends. We explored the Bay Area some more. Like there was a lot of time to do other things once you sort of hammered down how you wanted to study, how you wanted to learn, what ways work best for you. Third and fourth years, when you're in the hospitals and clinics, you have to be there and you're part of the patient team now. So it's a lot heavier on responsibility. So there, your schedule varies with the rotation you're on. So surgery, I was waking up at 4:30 a.m. every morning. I was going home really late. But pediatrics, when I was on outpatient, it was like a 9 to 5 clinic schedule. So, I was waking up at 8 and going to clinic and then getting home by 5:30, 6 p.m. So it varies based on the rotation you're on. It's also a lot more emotionally taxing. So you see a lot of people get sick, a lot of bad news be given, you see people die. You have patients die, and you learn with your interns and residents how to do a death exam or how to give really bad news. So it really is emotionally taxing, and the friendships and relationships you develop during your first 2 years when you weren't as busy and didn't have enough or a lot of responsibility, those really come into play during your third and fourth years because those people are going through the same things with you. So you really need to call on your support systems to help you get through times like that. But third and fourth years are amazing because you finally feel like you're in medical school. You're actually part of the team. You're making decisions. You're writing notes. You're talking to patients. And as a medical student, like, you always get saved if you make a mistake. There are so many people above you that nothing you do, unless you go completely berserk and act out of turn, nothing you do will ever hurt a patient because people are checking your work at every other level above you. So it's really nice because you get to really talk to patients and learn more about them and circle back after rounds and spend more time with the families and patients because you don't need to write as many notes. You don't need to put in as many orders. You get to really learn about the patients and who you're caring for. So I think third and fourth year of medical school is a really, really special time. It's really hard, but it's also really rewarding. And if medicine is for you, you're gonna really, really enjoy those years. Any other questions?
Oh, okay, I'll go then. How did your experience as a minority student or minority future healthcare provider inform your journey in healthcare education and your journey in healthcare training going forward?
Yeah, it just makes you want to be better so that people can recognize minorities and women as future doctors and as doctors and not cleaning staff or as nurses who are amazing. I got mistaken for a nurse so many times, and I was just like, I'll take it as a compliment because I don't have the patience to be a nurse, and I do not have the grace and the amazingness in their hearts that nurses have to be a nurse. But it just made me want to be better because as someone who is Filipinx and who is a woman navigating the hospital system, you are looked at a lot different. You're not expected to be as authoritative. You're not even thought of as part of the actual med student and doctor medical team sometimes because so many cleaning staff, so many admin people, and so many nurses look like you. So you just really want to be better, and you want to continue mentoring people who are younger than you so that more patients have doctors who look like them. I could go on and on and on about this, but I really do think that lifting while you climb is a big part of my growth as a medical student, and making sure that while I'm working to further my career, I'm also helping lift other people like me up to make sure that they have role models and have people who they can look up to too.
Thank you.
Yeah.
Okay, so I know you're going through your residency interviews right now. I just
Yes.
want to ask how is that? How are you doing? If you know, or is it too early to even call where you would like to land for residency, or if you have landed already?
Yeah, so I've only had one interview so far. Interview season is November, December, some even in January. So it's too early. I am really, really interested in Stanford Med though, because it has such a really good child neurology program. UC Davis does not have a child neurology program, or else I would have applied there. But I'm really interested in Stanford Med. I'm looking all over the place, not closing off any options and trying to remain open-minded. This is a long way down the road for you guys as undergrads, but when or if you do, for those of you going to medical school who will be applying to residency soon, make sure you sort of seek out really good mentors and advisors throughout the process so they can kind of calm your fears and tell you, you know, what is worth worrying about versus what is not, because I'm a really big worry wart. And thanks to my advisors and mentors, a lot of those fears and anxieties have been calmed down.
And what can undergraduate students like us do to stand out in medical school or like to medical school, like admission officers?
Oh, yeah. So I think just showing your passion in something and not thinking about checking all the boxes to what a good pre-med student is really stands out. So med school admissions offices see, you know, the whole general resumes of medical students or medical applicants, medical student applicants all the time. They see like 1 to 2 years of bench research. They see, oh, you went to this free clinic for a couple of like hours every month. You did all of this stuff, but what really stands out if it shows that someone who's really passionate about something and spent a lot of time and went really 100% in a project, instead of like them doing so many different things and not really giving their all to a certain project. So whatever you're passionate about, it might not even be medicine related. It might be arts, it might be humanities, it might be something that you can tie back to how hardworking you are, how passionate you are, what that brings to future patient care for you. Just showing that you're passionate about something and that you just didn't, you know, go along the route that pre-meds have to go along to get into medical school really ends up standing out. And also, if anybody has any questions about their sort of med school application, if they are applying to med school or things like that, my email was at the beginning of the presentation, and you can give it to all of the people that you're showing this to, so they can definitely reach out to me.
Speaking of med school apps, actually, that just gave me a question. So obviously med school apps, you have the GPA, MCAT, extracurriculars, but what is the most underrated or unexpectedly valuable piece of advice that you received about your med school apps, like what to include or what to showcase about yourself?
The really valuable part that I received, well, this part was not underrated because people always talk about it. Make sure your personal statement has been read over by tons of people to correct for grammar mistakes, but also to make sure that, you know, you are coming across as you want to come across and not, you know, giving off bad vibes with what you say about your personal statement. One of the most underrated pieces of advice that I was given during undergrad, I think during my sophomore year, was to make sure that you cultivate genuine and strong relationships with professors and faculty members, advisors, what have you, because these are the people that are going to be writing the strongest letters of recommendation for you. You don't want to get to, you know, the point where you're putting your application together and then have to scramble for people to write letters of recommendation. And then those letters of recommendation are probably going to be not very strong if you haven't already had a relationship with these people.
Okay, so I know we went over how to get connected with research opportunities already earlier, but we have one question asking, how do you get connected with pre-med experiences in general? Because at least right now, it seems very challenging to find some, especially without any in-person or not a lot of in-person experiences right now.
Yeah. I mean, these virtual shadowing experiences are really helpful, but if you really wanted to go the extra mile and try to connect with faculty members and physicians who want to help people who are pre-meds shadow in clinics and things like that, at least virtually or through telemedicine, I would honestly first go to like the medical school office life or medical school life offices or whatever you guys have at UC Davis Med. I would reach out to medical students to see who are sort of the educators that go above and beyond to educate and give students really good experiences. I'd reach out to those who are advisors in the medical school, because they're signed up to be advisors because they really, really are interested in helping students become better in their careers. So I would start there, because there are lots of doctors who are already overwhelmed, who don't want extra responsibilities, who don't want to deal with getting pre-med students onto sort of telehealth or virtual visits. But I think the ones who are already sort of self-selected as advisors would be where you want to start.
This is kind of pretty broad, but since you're like excelling in med school, maybe you can share some study tips with us in undergrad.
Yeah, when I was an undergrad, was so much easier than med school, actually, during the med school, like first and second year, because for me, it was because I took 2 years off between undergrad and med school. So I had to learn how to study again for med school after working for 2 years. When I was an undergrad, what I really did was sort of wrote out my own outlines and my own notes, because the fact that you are writing them out and you are making the outlines instead of just taking other people's sort of note decks or outlines from the internet or from study groups, the fact that you're making them makes you relearn the material again. So that was one of the big things that really helped me during undergrad. And then also when I was struggling, reaching out to your study groups or reaching out to your TAs and going to office hours, there's like no shame in being that student who is at every office hour, because then if you end up getting the material at the end and understanding it, then all the more power to you, just reaching out to the resources that you do have. Stanford had a lot of good free tutoring resources, and I'm sure that UC Davis has some of that too. Any other questions?
All right, I got one. So a Gen member asked, there's a lot of fear, sometimes even stigma, about the specific med school that you go to. And obviously there are rankings, and some schools might be looked at as really prestigious. But on the other end of that spectrum, does it really matter what med school you go to as long as you can make the most of those opportunities? Or is there really a reason for the stigma?
Yeah, so I am going to be very frank right now. First, I will say the caveat to what I'm about to say is that if you go to an accredited medical school, you will get a certain level, like a good level of education, no matter what medical school you go to, as long as it's one of the accredited ones, not one of the ones that are like, off in some island nation or something like that. As long as you go to an accredited one, you're going to get a really good, like basic foundation for medical school. I will say that going through the residency application process, the prestige, it shouldn't be like this, because the medical school you go to does not define how good of a doctor you're going to be. But I will say, going through the application process, of the prestige of the medical school that you went to, specifically for me, Stanford, goes a really long way. Not because the fact that you're Stanford makes you a better student, but because the fact that you're Stanford gives you the big Stanford name behind you, gives you the networks and the advisors and the mentors who are well networked throughout the country to sort of vouch for you and call their friends about you and tell people how great of a student you are. So even though, the medical school education is probably going to be, just as good anywhere you go, you get a lot more opportunity at one of these bigger medical schools. It shouldn't be like that, but that's kind of how it is.
Yeah, that makes sense. Speaking about medical schools in the middle of islands, there is actually a lot of interest, but also a lot of stigma surrounding Caribbean medical schools. There are a few accredited schools in the Caribbean, and a lot of our Gen members are wondering about maybe, is it worth it? Is it still is it still a perfectly valid option to go there?
It's a perfectly valid option, of course, to go to an accredited school. However, I will tell you that even the accredited schools are really, really hard, will set you up for difficulty in your future. So even some of the accredited Caribbean schools, they don't have enough spots for your 3rd and 4th year clinical rotations. So they're not pass fail. They're actually graded, they're ranked, and they cut out people as they go along of the medical schools. And I know this because I know people who have gone to the Caribbean schools and have gotten through it. So like one of the really big ones in the Caribbean, I forget what the name is, but they don't have, because of the resources of the place, they don't have enough room for learners in their 3rd and 4th clinical years. So they don't let the people who score below a certain like ranking advance to 3rd and 4th clinical years. And then at the same time, when you apply to residency, it is so much harder for you to get into a really good residency program, or to get into a residency program at all coming from one of those schools. I would say if you do not get into medical school and you need to like settle for one of those schools, that I would just spend a year doing research or doing something that you love and bolster your application so that it's easier for you in the future to go to a good medical school and have an easier path towards residency.
Thank you for the answer.
Yeah,
That was a
sorry.
long
It
one.
might not be the most popular answer, but it is the most honest.
Yeah. Whatever we can get. The best that we can get is always good.
So it seems like we have time for one more question. So this is a fact tradition where we ask every speaker who comes to our events of programming to just give one last piece of advice. I know you've given a lot during this session, so if you would like to leave our members with one piece of advice, what would that be?
Yeah, I already talked about my piece of advice during that session, so I'm going to make it different this time. Whatever you do as a future healthcare provider, always keep your patients centered at all of your actions. Make sure that patient education and your patient relationships are at sort of the highest priority for you throughout your career. And if you always do that, you're always going to stand out and be commended for your really good patient care. Try not to fall into sort of the greed that lots of people fall into when they realize that they can get more and more money for certain things, and just always remember the patients at the very end of the day.
Okay, awesome. Well, again, thank you so much for your time, Natasha. This was a very valuable experience for us as well as the Philam community at Davis. So we hope we're able to stay in contact with you soon, especially with like health conference next year, our biennial health conference. But yeah, just some concluding things for those who are watching this session. We're going to have a short quiz so that we can credit y'all with one shadowing hour, and we will plan to have these ongoing throughout the year so that y'all could get that experience with patient cases. So yeah, with that, we can close out this presentation, and we thank you all for watching this session if you are. And again, a final thank you to Natasha.
Yeah, thank you guys.